Okay, well, thank you everybody for coming to this controversial but exciting topic. I want to mention two things. Thanks for the people on Zoom, but we really changed the time to 1 p.m. on Friday, which is an annoying time, so everybody can be here in person. So please do your best to come here in person if you're not off. Second, I want to acknowledge Mike for taking the first hit in terms of APP, taking a shot and giving us some educational. I'm pretty sure I'm going to learn something. I'm really excited. He's a great guy with a very good voice. So without further ado, please welcome Mike to the stage.
All right. Thanks, Dr. Saad. I'm Mike with Neuro. I didn't realize this was going to be a hot topic when I finally decided to do my presentation on this like 2 or 3 weeks ago. But here we go. Cerebral edema and hyperosmolar therapy. So my objectives, I just kind of want to like provide a basic background of stroke, both ischemic and hemorrhagic, and then kind of explain the pharmacology behind hyperosmolar therapy and kind of get into their use and practice. So the beginning might be a little bit of a snooze fest for some of you people out there that are much smarter than me, but you know, I learned a lot about the patho behind neurology and these meds and doing this, and hopefully you guys can learn a little too. So ischemic stroke, nice picture here, but for better or for worse, it's the cessation of oxygenation to the brain. Usually occurs acutely in the setting of atheroembolus or cardioembolus, small vessel disease, and the like. The ischemia often leads to a bunch of different inflammatory processes occurring, and you know, ultimately the cells end up dying in the brain if they're not oxygenated appropriately, or you know, if they're part of the core, they just die. And then along with the tissue death that occurs, often we see edema, especially in the case of like a large hemispheric stroke. And there are 3 significant types of cerebral edema that we'll kind of talk about in the next couple slides. So this is just kind of a graphic here that kind of paints a picture of the 3 different kinds of edema. And, you know, edema is no good for the most part. The Monroe-Kelly doctrine kind of tells us that like the sum of all the contents that are contained within the skull are fixed. They have a fixed volume, so that's blood, brain, and CSF. And if you introduce anything else into that, you know, it's not really good. So, you know, we know edema in the brain is not really ideal. So as defined by the Monroe-Kelly doctrine, when one or more component of the intracranial contents acutely changes, compensation has to occur, or, you know, it's kind of catastrophic. One or more of the defined components has to change in order to accommodate the space occupying mass, whether that's, you know, a lesion or hemorrhage or whatever it may be. And with increasing edema, we see some increasing ICP, and the more pressure that occurs, the more damage that kind of ensues, and it's more of a decreasing opportunity for reperfusion. Cytotoxic edema usually occurs early in stroke. There's no associated blood-brain barrier disruption. Usually it's caused by ATP depletion, and it's characterized by swelling of the astrocytes and the neuronal dendrites. And ATP depletion due to diminished brain blood flow as a result of ischemia leads to impaired ATP production. And then failed ATP production leads to impaired sodium transport, which kind of leads to swelling. And then ionic edema is kind of the middleman between cytotoxic and vasogenic edema. It often occurs with blood-brain barrier breakdown and usually around 4 to 6 hours after stroke, acutely after stroke. Usually the edema stems from blood and CSF. Initially, the edema is seen only in peri-infarct regions, and it's then kind of exacerbated by CSF influx and then impaired interstitial fluid efflux. And, along with this, we can start seeing some damage occurring within minutes of stroke. And then cell death usually reduces the ability to clear interstitial solutes, and it exacerbates the edema formation. And then osmotic gradients kind of allow for new water to shift from the capillaries into the brain parenchyma itself. And then vasogenic edema occurs kind of once water and plasma proteins leak into the interstitial brain components, and then oxidative stress occurs because of blood-brain barrier disruption. There's mitochondrial dysfunction, and then serum protein extravasation. So it's really important to maximize blood pressure to maintain cerebral blood flow and perfusion, and maintain ICP high enough to counteract the edema, but low enough to maintain cerebral oxygenation as well. So ultimately, the edema and its formation will contribute to the final result, which is, the death of the tissue and how much can be salvaged. So then we'll talk about blood in the skull. Traumatic injury is a very common cause of bleeding, and it causes injury directly to the brain parenchyma and leads to neuronal injury that's kind of exacerbated by hematoma expansion and perilesional edema. And then a similar edematous phenomenon occurs with spontaneous bleeds, like hypertensive bleeds, aneurysmal bleeds, so on, and hemorrhagic conversion. Osmotic gradients are disrupted, and that leads to plasma protein extravasation, and ultimately osmotic pressure increases while hydrostatic pressure decreases. That leads to vasogenic edema formation. And then erythrocyte lysis and hemoglobin toxicity contribute to delayed cerebral edema, and vasospasm and ischemia begin to develop as a result of tissue oxygenation impairment. So it's suspected that the edema after an ICH is as a result of blood-brain barrier disruption from the lyse RBCs, which are kind of an irritant to brain tissue. Blood in the brain is just not good. And then it's suspected that there's a decreased perihematomal tissue oxygenation that causes swelling and edema. So when ICP increases to greater than 40, we start to see significant increased mortality, and it exponentially increases once it surpasses 20 to 25 millimeters of mercury, kind of just alluding back to the Monroe-Kelly doctrine. There's just nowhere for all those contents to go. So then transitioning to hyperosmolar therapy, we'll talk about mannitol first. So mannitol has a variety of FDA-approved uses. It's a crystalline osmotic diuretic, and we usually use 20 or 25% here. And the standard mannitol dose, from what I could appreciate, is 20% times 1 bolus with 1 gram per kilogram, followed by repeat doses of 0.25 to 0.5 milligrams per kilo every 6 to 8 hours. Most importantly for us, mannitol is approved by the FDA for reduction of ICP and brain mass. It's got level 2 and 3 evidence in patients with increased ICP after TBI. It does not cross the blood-brain barrier, but there's an asterisk at the end of that that we'll kind of discuss a little bit later. And then peak ICP reduction typically occurs around 30 to 45 minutes after giving mannitol, and then diuresis usually occurs like 1 to 3 hours after, and the effects generally last around 6 hours on average. This little picture is just like a representation of the blood-brain barrier, and You know, mannitol does not really cross that typically, but it helps prevent tubular reabsorption of water and increases excretion of sodium and chloride. And it draws water from the extracellular space into the vasculature. We see increased cardiac preload and increased cerebral perfusion pressure. Early plasma expansion with reduced blood viscosity improves cerebral microvascular flow and oxygenation, and increased intravascular volume, increased cardiac output. Late vasodilation can occur, and thus actually reduces cardiac output as a result of intracerebral autoregulation. And then compensatory cerebral vasoconstriction in the brain, where autoregulation takes place, leads to improved regional cerebral blood flow and reduced ICP. The amount that ICP is reduced is directly related to the amount of mannitol that these patients get and the concentration. So thus is the dose-dependent ICP reduction. It is only mildly metabolized by the body, and it's excreted rapidly by the kidneys. It must be given via filtered IV infusion because of the crystallation properties. And it's best when used as a rescue treatment, such as in cases with severe cerebral edema and imminent midline shift and brain compression. And it's not to be used prophylactically. So it comes with a variety of risks and contraindications, many of which are pretty profound. It's contraindicated to use mannitol with anuric patients due to renal disease, with pulmonary hypertension or pulmonary edema, in the cases of active ICH, heart failure, severe dehydration, current electrolyte abnormalities, and caution with renal impairment. So if it sounds familiar, it's basically every single patient that comes in the hospital has many of those comorbidities. So mannitol is just kind of risky, given it alongside those patients. We're generally not using it unless it's in a really sick patient who has many of these pre-existing conditions. As indicated earlier, it doesn't cross the blood-brain barrier in otherwise healthy vessels, but in the case of an intracerebral hemorrhage, mannitol can infiltrate the blood-brain barrier and cause significant and fatally worsened cerebral edema. So it should not be used in cases of ICH. You should monitor hourly urine output because of the risk with renal failure. And it's often used intraoperatively in pretty high doses for renal protection, but can lead to acute tubular necrosis and metabolic acidosis through toxic buildup within the bloodstream. And early rapid fluid shifts can exacerbate existing heart failure. It can cause pretty profound rebound cerebral edema and an increase in ICP in already hypernatremic patients. It's most effective used early in therapy. It's less effective with repeated doses. And, as our bodies are always kind of trying to maintain homeostasis, the more we give mannitol, the more they try to normalize the serum osmolality and kind of make it our new normal. So, you have to stop mannitol once you reach a serum osmo greater than 320, which is kind of difficult to do, but you want to use it early and not as a prophylactic, just when you start to see this edema. And then, obviously there can be many, pretty profoundly bad effects with mannitol, but it's often very good in cases of rescue medicine as cerebral edema worsens. But, just to repeat, the Neurocritical Care Society highly recommends against using it as a prophylactic because of the significant risk for harm. And then moving on to hypertonic saline, it's approved by the FDA for increased intracranial pressure. They recommend symptom-based bolus dosing rather than sodium target-based infusion especially for stroke. There's no real standard dosage protocol, but kind of expected to maintain serum sodium less than 155. And basically how hypertonic saline works is that it increases the intravascular volume via osmotic gradient. There's less significant fluid shifts that occur with hypertonic saline compared to mannitol, but we still do see some hemodynamic effects with hypertonic saline, like increased MAP, increased stroke volume, and increased cardiac output when compared to isotonic fluids, at least. And then the increased blood osmolarity and serum sodium in turn stimulate ADH release by the body, and that's when we start to see some pretty significant hemodynamic effects associated with fluid shifts. And then it relaxes arterial vascular smooth muscle and reduces endothelial cell edema, improves cerebral microcirculatory flow, expands intravascular volume, and augments cerebral perfusion pressure, leading to a reduction in ICP and edema. So some of the contraindications to hypertonic saline include, heart failure. It can exacerbate because of the increased intravascular volume. It can cause some pretty profound hypernatremias in a lot of patients. And, it's a tough call between when to stop it, at least based on our current protocol, so as to avoid really profound hypernatremia. Ultimately, both of these therapies have been proven useful in cases of cerebral edema, especially with brain compression and increased ICP. But we can't really overlook the contraindications. With hypertonic saline versus mannitol, there's significant evidence that many studies involve these two agents, and many of them are retrospective studies, meta-analyses, or involve low-quality evidence. So there's not a bunch of really high-quality evidence, unfortunately, including both of these in direct comparison. And there's a pretty profound lack of randomized controlled trials associated with these. And although these agents aren't necessarily indicated in order to improve long-term neurological outcomes, they have been really valuable for many different reasons, including hypertonic saline helps to improve both cerebral perfusion pressure and cerebral blood flow, similarly to mannitol, but hypertonic saline's also been proven to improve cerebral oxygenation, unlike mannitol. Hypertonic saline causes a quicker sustained intravascular volume expansion as compared to mannitol, and it can help reduce the ICU length of stay, which can help with the cost-effective care as well. And there's a greater reduction in daily ICP burden, which is defined as hours per day with ICP greater than 25, and a cumulative ICP burden defined as number of days with an ICP spike to greater than 25 with hypertonic as compared to mannitol. So mannitol has just been less effective in reducing ICP burden compared to hypertonic saline. And then just when discussing implementation of these therapies, the Emergency Neurological Life Support recommends a tiered approach. So tier 0 is basically many of the non-invasive kind of nursing measures that we can do. And then tier 1, we see the greater risk, but the greater likelihood of improvement. And usually tier 1 is when we start to implement these therapies. And you can consider surgical decompression in the really severely sick patients. But often we start these therapies in tier 1. Going into research, so emergency neurological life support, in addition to the many non-invasive things that can be done, ENLS supports the use of hyperosmolar therapy and the reduction of ICP based on their tiered approach. And these therapies are included in tier 2, as discussed a little bit earlier. ENLS recommends bolus dosed hypertonic saline therapy with 23.4% and every 4 to 6 hour serum sodium checks. Mannitol is also a reasonable choice to reduce cerebral edema, and they recommend giving 0.5 to 1 milligrams per kilogram every 4 to 6 hours. The Neurocritical Care Society, although there's overall low quality of evidence, the NCCS recommends administration of hyperosmolar therapy in cerebral edema with brain compression. There were a large number of articles that were reviewed based on 16 PICO questions, and the trials included many meta-analyses that contained prospective data, but many of them were considered retrospective observational studies. So again, kind of low quality evidence, but nonetheless, the Neurocritical Care Society still recommends using these agents, and often hypertonic over mannitol, in big brain bleeds, big ischemic strokes, and with cerebral edema. The Journal of Neurosurgery is kind of the same way. So these are 2 studies up here conducted directly by the Journal of Neurosurgery. Study number 1, you can see concluded hypertonic saline was more effective than mannitol in lowering cumulative and daily ICP burdens. And then study 2, we saw 64% reduction in mortality at 2 weeks. Just going a little bit further into it, study 1 included 25 matched patients to either group, and 25% received mannitol, 20% boluses, and 25 received hypertonic saline. 24 of whom received 3%, and 1 received 23.4% boluses. The mean cumulative ICP burden was found to be 15.52% with hypertonic and 36.5% with mannitol. So you can see that hypertonic just improved the ICP burden as compared to mannitol. And the mean number of ICU days with mannitol was 9.8 compared to 8.5 with hypertonic. The 2-week mortality rate was lower with hypertonic compared to mannitol, but the difference was not statistically significant. The p-value was 0.56. So basically the conclusion is that with adherence to the guidelines published by the Brain Trauma Foundation, there is a significant reduction in mortality rates associated with the use of hyperosmolar therapy, and mannitol has level 2 evidence in TBI and increased ICP, but hypertonic saline is kind of viewed more these days as a superior therapy. And then study 2 by the Journal of Neurosurgery, although it had its limitations in its primary objective, as well as the fact that it was just a meta-analysis of prospective studies, these studies still concluded that implementation of hyperosmolar therapy helped to reduce mortality at 2 weeks compared to no intervention, and it was beneficial in reducing mortality associated with increased ICP. And then this medicine by Wolters Kluwer, the systematic review provided a lot of good information. Its research kind of dove into a bunch of also different studies. Primary objective was a change in the ICP from baseline to termination of the medicine, and a secondary objective of change in ICP at 30, 60, and 120 minutes after terminating hyperosmolar therapy. And there was no really statistically significant difference at 20 minutes between the 2 agents. But hypertonic saline was more effective in reducing ICP than mannitol at 60 and 90-minute intervals. And the last study that I'll go over is by the Canadian Journal of Emergency Medicine, and they actually kind of provided an alternative viewpoint, wherein the other studies that I went over seem to altogether recommend using hyperosmolar therapy, and in particular, hypertonic over mannitol. The Canadian Journal of Emergency Medicine found that neither were profoundly useful in improving ICP and cerebral edema. Essentially, they say that hypertonic isn't really effective at all, and mannitol they could recommend, but they were wary of the risk of the diuretic effects and the effects on the kidneys with mannitol as well. The risk of ATN. So going forward, it's kind of beating a dead horse, I guess, but essentially all of the studies that I could find recommended using hyperosmolar therapy when confronted with the problem of increased ICP in patients with cerebral edema, no matter the cause, and specifically using hypertonic saline in the cases of ICH. So many of the neurologists here in our group kind of differ in their opinions on which agent to use, when, the target measurements, and the therapy goals. It's pretty clear that obviously these agents can pose a risk, but usually they're very valuable in cerebral edema, especially in the vasogenic phase. The symptoms and contraindications, as well as the body's remarkable ability to always try to return itself to homeostasis, kind of render these agents better used as rescue measures than prophylactics, as we kind of talked about. And, just again, kind of talking about the risk of hypertonic and mannitol, it'd be better to use them when you start to see this cerebral edema rather than before it develops. So the generally accepted standard implementation of hypertonic saline seems like more people use a bolus approach than they do a continuous infusion, unless you're talking about like a traumatic TBI. Hypertonic saline bolus dose is usually given through a central line. You can often do just one dose through a peripheral, but it's available in 30 ml doses. And typically up to a sodium level of 155, but it can kind of be pushed up to 160 in patients that may not be responding. And I couldn't really find a timing protocol for the bolus dosing. It's more patient symptom-based bolus dose rather than, a sodium target base. That's all I got. Any questions? Thanks. Yeah, either. Go ahead, Jay.
I just had two questions. One was, within the studies that you looked at, was there an agreed upon definition of what constituted cerebral edema?
I couldn't really find specific measures, that really constituted. Right. I couldn't really find any specifics about cerebral edema and like what was considered, severe versus, early developing or anything like that.
Agreed upon timing? But once, say the definition, since we're not, the truth is that there isn't really kind of an agreed upon definition for cerebral edema and how you can sort of determine whether it's going to end up being malignant or not. So typically, if you have early midline shift within 6 hours, greater than 1/3 of the MCA involved, that you could potentially be dealing with that. But was there any sort of timing that once you said, yes, we have the edema, when you initiate it?
It all just kind of seems subjective, you know, it just seems like a very subjective therapy, unfortunately. There weren't really any specifics that went into it. I think some people instituted it much earlier than others. But I really couldn't find like a baseline edema where it was usually enacted, unfortunately.
And some of the issue too, some of this is like just ICP. So how are all these people having ICP monitors?
Right.
I mean, how are you defining ICP elevation,
Exactly.
right?
Like sometimes you could say like, oh, okay, well, we presume that the ICP is elevated because
Yeah.
we can see that there is mass effect.
Right, but is that increased ICP really? Like it's pushing over, but I mean, there's always some room to swallow a little bit for an older patient.
And there's different types of edema, so cytotoxic edema, versus a reversible sort of edema that's associated vasogenic, right?
And these would be so hard too, because there's not in the institutions I've seen, every institution is different. Everybody does this differently, depending if you ask whatever institution A versus institution B. Some people use this bolus, some people use continuous infusion. I know where I trained it was continuous infusion, not intermittent bolus dose. Hopkins, it's infusion dosed, like not bolus dosed. I mean, the first initial one, it should be a bolus, and even the use of Mannitol and ICH. We use it in ICH. We use it all the time, right? Yeah. And it's tough. Is it really contraindicated? I don't know. I mean, in my discussions with other neurointensivists, it's used all the time. So it's a theoretical thing.
Yeah, I think that for, the use of this, I think that there clearly like frustration, like just on a sort of like even just institution basis of like, well, everyone kind of does it different, and then like institution to institution, well, everyone kind of does it different, and
right.
we don't really have agreed upon definitions or agreed upon timing, or when do we stop, or have we pushed the sodium way too far? Now they're in the ICU forever.
Yes.
It's like really high sodiums, yeah.
And we see that frequently, and nobody has a great answer. I mean, that's some of the issue with this. And I do think it's definitely reasonable to not do Hypertonic or to do Mannitol prophylactically Q6 hours. I don't think it's ever really made sense.
At my institution, we did hypertonic boluses. We did not use Mannitol unless we were like taking them in route.
If they're like actively herniating, right? Yeah, they're like
The concern was that rebound effect.
Yeah.
So like we're like, okay, well, if that's really what we're worried about, like about a rebound effect, then really we shouldn't be like hanging them out on the floor with like the potential for deterioration. We can't really guess the timing as to when they're going to diurese and then have a rebound. So we only ever used it when we were taking them to the OR.
Yeah.
Yeah.
Makes sense.
There's not a good answer, and I don't know if you found a good answer in your literature review, but I wish there was protocols like, hey, this size stroke, you image them in 6 hours, and if there's early midline shift, then initiate a bolus of hypertonic saline or just an infusion based or anything. But I'm sure you can find them.
What is it, like Widgix? He's the guy that does all the neurocritical care stuff.
Yeah.
That he was a part of, like, with the AHA, like American Heart Association / American Stroke Association, coming up with guidelines. I mean, they're still outdated. They're like 2014, but like I don't think that our technology has actually gotten that much better.
It's still the same medicine. Yeah.
But essentially, it's just sort of like if you have greater than 1/3 of the MCA, if you have like early midline shift within 6 hours, so that's sort of like repeat CT scan 6 hours after, if you're starting to see like early development. That you consider starting it then.
And I think if we want to be a little bit more evidence-based as an institution, we're going to have to start because we don't actually have any neurointensivists at this hospital.
Right.
Not the vascular neurologists are not neurocritical care doctors. That's the issue with this institution. There's not a single neurointensivist here. You're not necessarily trained that in vascular neurology fellowship either, right? That is a completely separate fellowship. And so you're having people, neurosurgeons are also not neurointensivists. And so we have people that are using these medications kind of out of their scope. And yeah, you do a little bit of it in residency. Of course, you do neurocritical care rotations, but you're not by any means a specialist with this either. And that is a detriment here specifically to Erlanger with no true neurointensivist that goes to the yearly NCS meetings. Or a closed neuro unit with closed, yeah. And now I think we have 2 guys that are interested in doing it. They're maybe sitting for the boards, maybe not. I'm not exactly sure where that's going, but still it is different. And so that is a detriment. And I wish, every time I discuss this with my colleagues that are neurointensivists, the theory and the rationale is different. So
yeah, I would say it is very interesting just coming at it from like, I think it's good that you did that sort of like, this is what the sort of like review within like the literature that is more focused to critical care versus more focused towards, stroke and neurology or neurosurgeons, is that like, there really is a difference in terms of the sort of academia that just gets passed down in training. And then there is just a different focus. And so making sure that there is some consistency in between that is always like a good sort of double check with reality to make sure you're just not like in your own like academic bubble.
Yeah.
From a stroke perspective, but
sure.
That is where I think that it would be beneficial to have, even like just somebody who is neurocritical care around, of course. But in the meantime, I think that even just some of the protocols that could potentially just sort of like, I don't think we do. Last time I was like on the inpatient side, we didn't have like an obvious hypertonic protocol or
There's
anything
not
like that.
one.
Because we
There's
had
an order
that
set, but that's not a
advantage, just,
protocol.
like would activate the hypertonic protocol, and everyone knew what that meant.
Yeah, no, as far as I know, I've been here for this is my end of my third year. There's not really a protocol. There's just people put people on hypertonic saline as needed.
Order set? You're like, we've all agreed upon at least this order set.
There's an order set and monitoring guidelines, but how
Yeah.
long, when to titrate down, when to titrate up is.
But even just from like a sort of like, if the stroke is of this size or has like early midline shift on her PCN in 6 hours.
Yeah. I think everyone's instituting at that point anyway.
Yeah.
I mean, that's pretty standard. I think people that's almost inherent. Just people, when you start seeing midline shifts, when you do it. I guess the question is.
The neurosurgeons like consistently take people to the OR for decompressive.
No.
Because really what this is a temporizing measure.
Yes.
This is a temporizing measure to get them through this like, dark valley of their admission. Hopefully they make it through, and that like really can we like get them through without a decompressive training, and hopefully we don't wait too long if they actually need one.
And the evidence for that too is early too. You're not even supposed to be waiting,
Well,
right? You're supposed to do it the first 2 days. So the whole theory about putting on is temporizing so they don't need it isn't real data. It's those studies were within 48 hours, right? And so usually they haven't
But did
trained
they
it
do
yet.
that? Because I've only like when I was on, there was only over one of them that was really good about.
It's mixed, kind of like how the use of hypertonic saline is. I know in our neurosurgery department, I haven't worked with everybody as much, but I know Dr. Wallace is very by the book with that. He's, if you're a candidate, you're a candidate, and it is he uses all the guidelines that, if it's depending on what side, depending on age, less than 6 years old can get it. Greater than 60 is, that's what the studies show, right? You're just kind of condemning them with life with disability, but saving their life, right? So I don't know about the other guys as well, but I know some do. Yeah, definitely use by the book protocol, kind of based off the evidence we have.
So because that what is like eventually comes down to, and this came down to when I was like, at Vanderbilt, but also here it's like you don't want to just sort of like rest on your laurels, like just don't rest on your hypertonic, be like, oh, it'll get us through.
Well, yeah, because it won't, because it's barely evidence-based.
And then you're like, uh-oh.
Yeah, and it is. We know it's just a bridge, right, to definitive management, which is surgical. But the thing, then you got to take a lot of other issues into mind, right? What is the goal, and how old is this patient, and is someone at 90 going to really get a decompressive hemicraniectomy ever? And the answer is no. So it gets a little dicey and complicated. But I do think here we can all probably sit down with pharmacy and with the neurology neurosurgery and make a protocol, because we're at a shortage of hypertonic saline and we're essentially forced to.
Yeah.
I prefer hypertonic saline much more to mannitol. I almost never use mannitol. People here, when I got here, specifically the neurosurgeons, would use it all the time, Q6 mannitol dosing, and I never understood it. But even there's some of the neurologists I think would do it too, but the modern trainers are not Q6 dosing mannitol. And I want to just to blame neurosurgery. It's just, that's what I saw when I was here. And then I don't see it nearly as much. I think people don't dose it that way very often anymore. But it was an old way to do it.
Yeah.
There's not like a great specific way, but I do agree with the whole don't do a Q6, and I agree with the. I do use hypertonic saline as an infusion rather than bolus dosing because it's sometimes really hard to say has their ICP unless you're scanning them like 4 times a day. How do you really know? People are coming with aphasia and obtunded mental status to begin with, so how do you even know if they're really getting worse unless they blow a pupil? And so you can see it early unless you scan them every couple hours and start seeing more and more midline shift, and you just bolus them with every midline shift. Like, when is the indication to give them that extra bolus?
No, I think that like the way that we use boluses at Vanderbilt wasn't based necessarily on symptoms, which is I guess different than that. Like I mean, you are using them as symptoms in the sense that like presumably when somebody has cerebral edema, they are going to be like sleepy, obtunded. You're not going to have as good a neuroexam as you had when they like initially presented. But it wasn't, oh, we're only going to give it if they're not doing well. It's kind of like once you started the bolus protocol, they were on the boluses. And there was some thinking among the neurocritical care folks there that like because of the sort of diminishing returns that you sometimes get with hypertonic and mannitol, that you don't want to just sort of like allow like a sort of like homeostatic drift. We're like, oh, now this is like our new like sodium, like, and it's not really going to shift any fluids.
And that makes sense.
So that like with bolus, you're getting more fluid shift, which is what you're trying to do in order to get the edema down.
Yeah, no, that makes a lot of sense, and I get it. It just, if you're, so were you guys just bolusing it every 4 hours as a bullet or as a 250 cc of 3%?
So we would do like the 250 cc's at 3%.
Okay, and just every like 6 hours, 8 hours or something?
Yeah.
What's the initial bolus you're giving IV look like?
It's 250 cc's
Same
of
thing.
3%, but it's only 30 cc. If you give them a bullet of 23.5%, it's a one-time IV central line 30 cc, just kind of a
What's the IV bolus you're giving, not the central line one?
250 milliliters.
Okay.
Yeah.
But we
of
also
3%.
had like it was a lot easier just to have
The same
people
thing.
have central lines anyway, so that we had options.
What was that?
I just feel like it was easier because we had the neurocritical care, right? Like to make sure everyone had a central line. Was
Right, here it's harder to do, right?
Right.
Not everyone in the ER is getting a central line. There's nobody's going to have time to do that, and there's no neurocritical care to go down and put central lines in everybody. So it's just when you have no choice, you can't do. Most people can't get a bullet in the ER unless they're really doing poorly. Then I've given a bullet here a few times because they have to go back to the ER, get their central line tubed, and then they get it. Yeah. But by the time that's happened, they've already herniated. So I give that in those patients. I give them mannitol and hypertonic saline, 3% and a dose of mannitol because you're trying to buy time and hyperventilate them until you can get that central line in anyway. At the end of the day, it probably does work to a certain extent. I mean, but it's all temporizing. I mean, it's none of it is definitive.
right, and I guess that was always like the big tension, and I think it continues to be the tension. Is just sort of like then you're just gonna have to go based on someone's like I don't know, like personality match, right? Like the neurology personality match with the neurosurgeon personality match to be like, so when are we gonna pull the trigger?
Yeah. The good news is our neurosurgeons are all
OR.
very nice and easy to work with. I mean, there's no guy here that's like tough to work with. So it's just
No.
it's not like that everywhere, as you probably saw some other places. Here, it's people that are good. I mean, it's it's just sometimes tough if they're gonna do it.
I think it's just like about like radar.
When do we
like,
do it? Yeah.
Everyone's like sort of like radar setting in a sense, right? It's not about like, oh, they're not willing to take it, but it's just sort of like how jumpy
Yeah.
everybody is to take it.
It doesn't want me to listen to you.
Sorry.
Lauren's gonna say a couple of minutes about the shortage. We need to do policies as well from the get-go. And I don't know, I like it personally.
We probably have to though, right? If we don't have enough to give an infusion, do we just give them?
It's the same thing at the end. I mean, usually you give 100 every 4 or 250 every 6. You follow the sodium as I don't know, for some reason the mechanism of delivery show that some studies better resolution of the edema than the although it's the very same amount being delivered.
Based on what Megan's saying,
Kind
it's
of
more
like
because you're actually getting
homeostatic
fluid out intermittently rather than just homeostatic.
Yeah.
It's just that it equalizes or so.
I have just a question. With COVID, I'm guessing a lot of patients have
everybody can do.
Yeah, 3 days right now is pretty common. Yeah. Yeah.
Is the ED comfortable with giving like hypertonic saline?
It better be. It's part of their training. Yeah.
Okay. I was just curious. I haven't, like given up on like.
No, they can give it. We give it, but they're fine with it. Yeah.
I think one exciting area of like future research with both Mannitol and Hypertonic is about the risks of acute kidney injury with either. So like more evidence is coming out that using Hypertonic and causing a hyperchloremia in addition to a hypernatremia is leading to acute kidney injury, and should we be using buffered solutions, bicarb solutions instead of 3%, which is what we're doing now during the shortage anyway. And I know you mentioned with Mannitol monitoring serum osmolality, and that's something that we do here to kind of for ease of nursing, right? It's a number that they can look at and hold if they have an increased serum osmolality. But there's evidence to suggest that an osmolar gap might be more indicative of predicting acute kidney injury over just a serum osmolality. It's just something that the bedside nurse probably would be able to calculate. That's something that us providers can help kind of stratify that if we have to go to administering Mannitol during the shortage, which I know is not preferred.
And again, just kind of comes down to like, we're trying to save the brain. We're not really thinking too much about the kidney. Like,
Right.
Yeah, essentially. I mean, I don't use Mannitol on acute kidney. Like, if the kidneys are horrible, that's the one time I've never used Mannitol there. But what choice do you have?
Right, right. No, I agree.
and it really, again, kind of comes back to sort of, we won't, if there is a protocol that all the, providers kind of agree to, where when we would sort of agree that this is when you do hypertonic, and this is when you would take for a trainee, and this is when we would potentially, consider discontinuing or holding or stopping, then that would also probably also reduce any sort of kidney problem.
Yeah.
Just have less exposure.
But you brought up a good point. Like, the kidneys they'll probably recover, but the brain won't. So,
Yeah.
Or they'll die without it. So I mean, we know it's reduce mortality at least. It's not going to change our outcome in terms of walking or talking or living a quality of life in a lot of the cases. So that's the whole point of it. It's like, well, that's probably why we're doing something different. We know the outcome isn't necessarily different, maybe other than they may live, but locked into a level of severe dependency.
Right. Well, that's why you're never going to have a good study, because it's like you can't do a randomized controlled trial of like, so we'll give you this life-saving thing, but not you.
Yeah. Yeah. There's not equipoise, right? So,
Yeah.
I had someone pronounce that, I think equipoise or something once. All right, let's hear about the shortage though. I'm actually intrigued. I like everything I see, and I don't like Mannitol, so I want to figure out what
Yeah, I'm in the same boat as you. So I just touched base before I came with our purchasing person to see if there was a new timeline on the resolution of the hypertonic saline, and she said as of now there's no date of return, so we can't get 23.4, we can't get anything. So we were compounding 3% from 23.4, but we have no more 23.4 to even compound 3%. So as of last night, we're compounding only buffered solution. So it's like the hypertonic. So basically they take normal saline and sodium bicarb to make 3% hypertonic. So if you do end up ordering it and using it in your patients, just be mindful of acid base status, because you're going to give them tons of bicarb instead of tons of chlorides. You're kind of going the opposite of the spectrum where you would have been with 3% standardly.
But it's nice to have a critical care doctor that's not monitoring.
Right, because they would get maybe gases or check BMPs more frequent. Right. But I do. So I round on most of the neuro ICU patients now. And they do.
I like the pharmacists. I like to have a lot. We switched it now to our medical ICU doctors are taking over all of these kind of critical patients rather than hospitalists. Because then you have two non-intensives managing because you really need some sort of intensivist. So it will, because that's the life of an intensivist is I-nose and acid-base analysis.
Right.
Stuff, right?
So I think that now that we're kind of cohorted, I think it's going a little bit better. It's we have better communication between the groups and have more better plans for the day and what we're trying to achieve.
And people are going in and out.
Right. If we get beds, we can kick them out. So buffered solution is kind of the new what we're going to have to use from now on. But in the meantime, we still have Mannitol. The new issue with Mannitol is that we can't get Mannitol filters. So we're looking in, it's always one thing, it's not another, right? So we're going to have to use a different filter for Mannitol. We're going to reserve the filters we normally use for TPN patients. because they use the same filter. And then we're going to look into using a smaller size as long as it is able to be pushed through and like functions. So, you know, any like,
Well, this is an unrelated issue, but like, do we know anything about like the update on the CTA contrast solution?
all I know is that pharmacies compounding it for patients, like they pull up the doses. I haven't heard anything since because we're just kind of out of it. We're just like we were told to pull them up, and that's all I know about it.
I heard something about like maybe it'll be resolved by like July, August.
You know more than I do, so I don't know.
We still have it. We're still shooting it. I don't know what we're shooting into people's veins, but it's just still dying. So,
Look at wrong.
I mean, we've definitely been trying to restrict it from what I've heard, us in trauma are somewhat exempt because it's essential in a lot of what we do.
Yeah.
But you know, so we have been trying to be a little bit more strict about who gets it. Not everyone's getting it anymore. But really, kind of the inappropriate use came down to probably other specialties. You know.
Yeah.
But that's what they're used to doing, and you're gonna have contrast for everything. And I think that they've been cutting down too, though. I think everyone's been doing a pretty decent job. I have no idea what the supply is, but I was told it's not like Hypertonic we're getting done, right? There was still a supply coming in.
They were like getting it through like different vendor situations.
Yeah.
But they're like not going to be necessarily be able to rely on that going
No,
forward.
because it wasn't the same Omnifig, it was a different kind. Rather than stuff we're getting from China. And that I thought we were still getting, but much 80% less capacity. And then they're also trying to get other contrast. Yeah. But I know we did reduce the usage overall. I don't see any numbers about what percent was reduced and how many percent, but it's true.
They sent out like a thank you email that was like, thank you for everybody like reducing the number that you're ordering.
Yeah. I mean, I don't think we have to, right? We have to reserve really need it. Time in medicine. It's incredibly bizarre, you know, with nursing shortages and now material shortages. It's making inpatient life like much harder.
Do you have any questions? I don't really have a lot on this shortage updates because there's really nothing new happening.
So with our current buffer that we're just making up, like based off of this lecture, right? So this coincides with the lecture where we all kind of like Hypertonic more. But can we really, does it even apply right now? Can we even use it? I mean, if we're going to start, because the way we use it is pretty much anybody that's going to start swelling. We don't always start right away, but if they start swelling, that's when we started. Can we still do that, or are we just going to have to be forced to use Q6 Mannitol?
I mean, I'm still in the camp of Hypertonic, so I feel like it's appropriate in those patients, like until we absolutely can't do it. But then I have a feeling like because of this Mannitol is going to go on shortage because everyone's probably like buying it up because you can't get 3%. You still want to treat your patient. So second best is, you know, all you can get, that's all you can get. So I think that is going to become the next problem in this cycle for sure.
We probably should document. Anyone else should be writing this, like why we're not using Hypertonic saline. It's like, well, we don't have the appropriate natural shortage. I don't know what it means, but it's probably not. Just to remind yourself in the future, like say this ever comes back, say, well, that's why. There's a reason as to why we're doing. Like, why did this person get a CTA? They had some promise on their hemorrhage 24 hours later. It's like, well, their NH is 0. We didn't get a CTA because it wasn't indicated. We don't have an item that everybody was. So there's just, I guess, reasoning now to put in those for our NPs.
You mean like the little stuff where it was like due to the COVID-19 pandemic, the care that was delivered in
Yeah, the
ER
ER said everybody. Yeah, not that does anything.
a little
So
bit less awesome.
just make sure everybody finds that this is. I don't know. Let's say 20 years from now, someone goes through the notes. Like, well, yeah, that's great.
Yeah.
You know?
Get anything. Making normal making Hypertonic saline with excess bicarb.
Yeah. Is there any shortages predicted for anything else? Is that a question? I have?
It just comes at random, really.
There's shortages for everything.
Yeah.
Yeah.
It's just like, how does it impact what we do on a day-to-day? Like TPNs had problems for months, but now that's been resolved, and
Yeah.
digoxin was a problem, and then it just like it's just a cycle.
Just doing something that inhibits the duct's metabolism so you can lower the dose a little bit. Man, a little bit less of it. That's what we're gonna start getting.
We'll just get all of our
our patients alcohol, it actually increases their muscle.
Yeah.
Make them down there, it's a little.
That's what was worried.
Oh, no, I haven't seen it.
Yeah. It's weird. With how much alcohol is getting way too
Yeah, but I think that probably when it comes down to it, you don't really understand what's happening.
Why the healthier patients are the ones who get it.
You look so very good, thank you.
That was always the residents. I was worried about that.